We don't use it routinely, but it's very good. I mean, it should
I would advise you to start doing it as a routine. Why? If I have an MDI, meter dose inhaler, and I take it with a perfect, my technique is perfect, absolutely perfect. Do you know how much of the dose will go into my lung? Anybody? It's about 11%, 10 to 11% will go in my lung if my technique is perfect. If my technique is not perfect, possibly 0, maybe 1%. 1% of salbutamol will still do the trick. 1% of the nebulized inhaled corticosteroid will do nothing. It will only give you the local side effect. Okay? If you use the spacer, and the moment you introduce the spacer, the interface, you do not need a coordination. Okay? And the lung deposition jumps to double, more than double, 23%, which is exactly the same as nebulizer. You do not need nebulizer unless the patient is moribund or very, very sick. You can do exactly the same thing as you do with the nebulizer with your spacer. The other thing is, the big particle, the plume, when you press the NDI, there's a plume. And only 50% conforms to the respiratory particle. That is, the size is less than 5 micron. If it is more than 5 micron, it will just go and get deposited in your throat and your pharynx. And you don't need that, especially when it comes to steroid. So, by introducing an interface, all the heavy stuff, heavy particles, they fall onto the spacer. And the ones which are maybe say 5.5 micron or 6 micron, they get freed from the propellant and they become less than 5 microns, and so the lung deposition much better. So the cost of the spacer is back in about a month or so, because you are wasting less and you are getting rid of minimizing the side effect. I cannot say getting rid of side effect. So when it comes to inhaled corticosteroid, all my patients who are using MDI, they have a spacer. Anything else?